Bonjour, hello, and bonjour. I am happy you are here. My name is Dr. Kathy Kyle. I am the CVMA Director of Wellness and DEI, and your moderator today. My pronouns are she, her, and I'm coming to you from the traditional and unceded territory of the Siwetnik in the beautiful Shuswap Valley of British Columbia, where I am honored to live, work, and play. Thank you for joining the Merck Animal Health and CVMA Time to Talk About Mental Health and Vet Med webinar. And today's topic is the emergence of patient safety science and psychological team safety culture in Vet Med. This webinar will talk about medical errors, and you may be triggered with thoughts and emotions. There is help to be had. If you or someone you know is struggling, please reach out and share your story and tell others. Some contacts and ideas for getting help are on this slide. One good phone number, and it's super easy to remember, is 988. This is the Canadian Distress and Suicide Helpline. And ask someone you trust to help you make the call together. Talk with a professional healthcare provider. The CVMA website lists the phone numbers of counselors and psychologists available through many of the Veterinary Medical Association employee assistance plans. Take an image of the QR code, or soon I'll put all of these resources in the chat, so you'll be able to copy and paste them and keep track of that way. And calling these folks professional healthcare providers through the employee assistance plans, it's confidential, it's anonymous. Your boss will not know, your veterinary medical association will not know. And they provide a lot of support, including for crisis and suicidal thoughts. And then talk with a peer who's been through a medical error. And one way to do this is through the CVMA's peer-to-peer platform called Togetherall, which is sponsored by Western Financial, enabling this to be free for all Canadian veterinarians and student veterinarians. There are also other good ideas on the slide, and I'll be putting this information in the chat soon. And know that you're not alone today. We have a person on the webinar who is our safety supporter, and she's ready to listen and provide help if you need it. Her name is Dr. Karine Mayette. She is a veterinarian and a social worker, and she provides team training. And just a note that social workers are great to have on hand when you're debriefing medical errors. So in two ways, Dr. Karin will be available for one-on-one chat today in the Zoom platform. So reach out to her in the chat function. And then do consider reaching out if you do need help in your team and your clinic perspective down the road. So I'm going to transition the slide to the French slide, and Karin will provide some background on this slide. Thank you.
Thank you, Katie. Alors, bonjour tout le monde. Merck Santé Animale se joint à la campagne « Il est temps de parler de santé mentale en médecine vétérinaire » de l'Association canadienne des médecins vétérinaires, la CMV, et du Centre de prévention du suicide dans l'organisation du webinaire d'aujourd'hui, La science de la sécurité des patients, ainsi que la sécurité psychologique de l'équipe en médecine vétérinaire. Alors, c'est sûr que les sujets d'aujourd'hui peuvent être sensibles pour certains. Peut-être que pour d'autres, ça va déclencher une réaction émotionnelle. Alors, sachez que, comme Katie vient de le dire, je suis présente pour vous dans le chat pendant la présentation. Si jamais vous avez des questions, si jamais vous voulez en discuter, alors ça, on peut en parler en privé via le chat. Et si c'est quelque chose, si c'est une discussion que vous voulez poursuivre lors d'une consultation professionnelle ou encore, soit pour vous, pour votre équipe, je vais laisser mes coordonnées où vous pourrez me rejoindre. Des fois, là, on a l'impression que c'est juste trop. Puis je vous assure que dans ces cas-là, vous n'êtes pas tout seul. Sur la slide, excusez l'anglicisme, vous avez ici l'ensemble des ressources que vous offre la CMV. Alors, déjà en partant, selon votre évaluation personnelle de la situation, on vous invite fortement à aller rencontrer une personne de confiance parmi vos proches, parmi vos collègues. Sinon, que vous allez décider de parler à un professionnel de la santé. Alors, on a laissé ici les coordonnées pour rejoindre les conseillers et autres professionnels de la santé qui sont disponibles dans le cadre du programme d'aide aux employés de la CMV. Euh, Ensuite, on a une formation sentinelle. Vous pouvez rejoindre l'AMVQ si on a laissé l'adresse courriel. Puis également, Together All, c'est une plateforme numérique très intéressante. Ça, c'est le soutien par les pairs. C'est anonyme, puis on communique de façon écrite. Fait que personne connaît ne connaît notre nom, puis ça nous permet de vraiment nous exprimer librement. Finalement, il y a la ligne canadienne crise suicide. Alors ça, c'est en anglais et en français. Vous pouvez téléphoner ou texter le 988. Alors, je vais m'arrêter ici, puis je vais vous laisser profiter de la présentation. Thank you.
Merci. I am pleased to introduce our speaker, Dr. Rochelle Lowe, DVM MAS Master of Applied Science and MHL Masters in Healthcare Leadership. Rochelle is the Global VP, Quality and Patient Safety for Mars Veterinary Health. Dr. Lowe's clinical experience in emergency and critical care quickly helped her appreciate how much of an impact hospital culture and empowering and supporting nurses has on improving patient outcomes. As medical leader for VCA Incorporated, Rochelle's focus is on quality, patient safety, and patient care, and currently collaborating with Johns Hopkins to integrate team training, that's hard to say, and a culture of safety programs like Team Steps into Mars veterinary hospitals. Rochelle is a published author in the area of patient safety, psychological team safety, and workplace culture. Rochelle will help us learn how Swiss cheese is a metaphor for a systems-based approach to looking at medical errors and adverse events. And we will learn how this shifts focus from individual blame to more systemic factors to encourage that culture of psychological safety and team collaboration and coming up with practical solutions. You're in for a real treat. I had the pleasure of listening to Dr. Rochelle Lowe in 2023, and Rochelle is an engaging, practical, and informative speaker. Welcome, Rochelle.
Great. Thanks, Kathy. I really appreciate it. I will go ahead and pull up my presentation. Let's see. There we go. Are you guys, is that coming up full screen? Okay, excellent. All right. Okay, so today, like Kathy said, let me just see how we're gonna make these slides go forward. There we go. I wanted to share one of my many pit bulls. So I do have a tendency to rescue this breed, which I adore. This is Betty, and just spends most of her time exactly where you see her in that photo. But essentially today we're going to talk about patient safety, and I really want to share the concept of patient safety, but also actually the importance of patient safety data, and we'll talk a little bit about that. Kathy mentioned this, and I think if there's one thing that is really important today, it is actually something called a systems-based approach. And so we will go through that with a few examples, and then we'll finish with a focus on how these events actually impact us as health professionals. And when I say us, I mean every single team member. So not just veterinarians, it's definitely, you know, nurses and every other support team member in a hospital. So I wanted to start off with a story. Kathy mentioned my background is in emergency and critical care. And I was working on the floor one day. I was basically the primary triage person for the emergency team in one of our large specialty hospitals. And we received a call that there was a really critical case coming in. And this case was a hit by car. It was a severe polytrauma case. He was on his way in, and there was an emotional component to this case because this dog had actually fallen asleep behind the back wheel of the owner's truck. So not only was he hit by a car, but he was actually hit by the owner himself, inadvertently, obviously. And this dog meant everything to this couple. When Banks presented, he's a 4-year-old Jack Russell Terrier. He had, I mean, honestly, almost everything you could imagine was injured. So he was in severe shock. He had severe head trauma. He also had a diaphragmatic hernia, and his liver lobes were up in his chest. He was bleeding profusely intra-abdominally from a severe liver laceration. He also had multiple fractures. And so when when I remember this case, I think about how amazing our team was coming together to do everything we could do to stabilize Banks. And so we worked really hard over the first 24 hours to do that. Throughout that time, I let the owners know that he's a critical patient. We're going to do everything we can, but I wasn't able to give them a prognosis until we reached about 24 hours, and I started to see signs that actually we might be able to get Banks through. And I'm sure many of you have been involved in situations like this where it becomes a little bit bigger than just a single case, where everybody gets to know a patient that does incredibly well when you don't necessarily expect them to. And this was this case. So not only was Banks sort of fighting, everything he could do to survive this, but our team was doing incredible work to help him. But also his family were just amazing people. And so they would bring in, they got to know a lot of our staff. We had a staff of over probably 200 people at the time. They got to know the team. They would bring in dinners. It was just an amazing sort of relationship that developed. And slowly, day by day, I would say by 72 hours, I was able to tell them that I actually think Banks is going to pull through this. We just have to kind of go step by step and continue this level of care. And I remember, so we used to do, so I think it was about day 6 of Banks's care, where I was sitting in this area that we called the nurses station, which was where veterinarians and nurses sort of all kind of wrote their medical records and, talked to clients and gave updates on cases. And I was writing Banks's treatment sheet, and I inadvertently wrote the wrong dose of a medication for Banks. And this medication was given to Banks at that higher dose. And this happened to be not related to his injury at all, but this medication happened to be insulin. And it basically, the minute I heard what had happened with Banks related to these treatments, I realized what I'd done. And I just remember this sinking feeling, thinking, how could I possibly do that? And how could I especially do this to Banks, who had fought so hard to get through everything that he'd overcome? And I remember at the time just sort of being a little stunned. I was usually felt quite confident in what I was going to decide, and the path I was going to take as a veterinarian. And this definitely changed that a little bit, where I had to think, just sort of start to think, well, what do I do here? And I basically I remember thinking, what are the things I can do to care for Banks at this point? Like, what can I do to reverse the effects of this medication? I also reached out to our medical director at the time, and he immediately came down, and I told him what happened. And he put his arm around me and he said, Rochelle, these things happen. These things happen to the best of us. And he's like, let's just go fix it. And so essentially, I remember I worked closely with him on, how do I communicate this mistake to the owners? How do I tell them the plan going forward? And he gave me guidance on those kinds of conversations. But I think when I think back to this, I just remember realizing at the time that I was so lucky, because my teammates, the whole entire nurse team that was working with Banks, everybody sort of rallied around. And basically in the next 24 hours, we were able to stabilize Banks. And I believe it was about day 9 that Banks went home, and he did incredibly well. I, received Christmas cards from their family for many years after that. But I do remember thinking, I remember thinking at the time, is everybody in a situation where when those things happen and you don't really know exactly what to do, how does the team react and how much support do you receive? And so today, basically, I want to talk about patient safety. The whole real science behind patient safety. And essentially, patient safety is an applied science that involves systematic focus on errors and the rigorous design and testing of change interventions. And so I really want you to focus on that word systematic, because it's a really important word as we start to look at how we should be approaching these cases. And when I think of what is a patient safety event, a patient safety event is harm or potential harm caused by medical management or treatment rather than the underlying condition of the patient. And one of the important things to think about is when we actually look at this field, the patterns of error in healthcare are actually no different from the situations that exist in other high-risk industries. And so what I'm talking about are high-risk industries such as the airline industry, the automobile industry, nuclear power industry, and honestly, healthcare. And I think some people don't necessarily think of healthcare as a high-risk field, but it really is in so many ways. And we'll kind of talk about why that's the case. But what is different from these other high-risk industries is that there still in healthcare remains a culture, it remains an element of a culture of infallibility that still denies the prevalence of error. So what we tend to do in healthcare, and this is very much the same still in human healthcare as well as veterinary healthcare, is we tend to put veterinarians and clinicians, medical doctors on somewhat of a pedestal where, because they're working with patients, we can't talk about error. We can't talk about the fact that it's going to happen. And unfortunately, that is probably what's holding us back a little bit in actually creating safer systems and better outcomes for patients. So we'll talk a little bit about that. But one of the most important things is that medical error is very complex. And we'll go through some of the things that lead to medical error. But an error itself is an inevitable part of being human. And I would hedge to say that there isn't a person on this call today that hasn't made a mistake of some sort. Now, that mistake may or may not have affected a patient, but it also might have. And that is the kind of realization I think that we need to get to before to truly understand the science behind medical error. So this is not, medical error is not just something that happens to brand new veterinarians or, brand new nurses. This is something that can happen to the most experienced clinicians and definitely specialists as well. And so it's something that happens across the board, every single team member in a hospital setting. So what I wanted to do was share a little bit of patient safety data. They have been collecting in human healthcare patient safety data for over the last decade. And essentially, just to put sort of the amount of the sort of number on patient safety events and the amount that occur, if you look at in the US, that about 334 million people are admitted to US hospitals every year. Up to 100,000 people die as a result of medical errors. And when you actually put that in perspective with the way the ways other people die, that is actually more than motor vehicle accidents, breast cancer, and AIDS. And it's almost as much as all of those. It actually is more than most of those combined. So when we actually look at this usually is in the top 5 leading causes of death in the US. With inpatient care. And so it is a significant amount of things that happen. When we actually look at data globally, what we see is that 4 in 10 patients, and this is out of the World Health Organization, are harmed in primary and outpatient care. And I think really importantly to know is that up to 80% of these are preventable things. And that is exactly what sort of drives a systems-based approach in patient safety, which we'll talk about in just a minute. I wanted to share a little bit about just different examples of things that I've seen as far as medication or as far as medical errors. So the idea of an overdose of a medication is very, very common in our database in patient safety. So administration of 6 mils of ketamine to a cat as an induction agent, cefazolin given epidurally. A 2-year-old dog presented for a mass removal. We accidentally performed a neuter. 4-year-old Westie with a burn from a patient warming device, and a patient sent home with the wrong insulin dose. One thing I should definitely mention, if you look at the example of a Westie, which is basically almost, it could be an actual error, it could be an adverse event, just like a vaccine reaction. Well, in our patient safety system, we collect those as well. So when we talk about medication error, really, it encompasses adverse events. It encompasses anything that harms a patient. And I think if you think of it through the client's lens, whether it's a medical error or whether it's an adverse event, doesn't really matter through their perspective in most cases. It's the fact that something harmed their pet. So just to compare human medication for what we're finding so far in veterinary medicine, what you can see is a lot of similarities in the top 4 categories of things that we collect. So medication error, meaning any error related to the dispensing or inpatient administration of medication. Also under medication error, I'll just mention that also includes actually IV fluids. It includes everything to do with blood products. It includes vaccinations. It includes any sort of topical products. So medication is a huge category, and that is by far the #1 category in both our database and in human healthcare. If you look at the top 4 in human healthcare, hospital-acquired infection is second, and that is not something yet that we routinely measure in veterinary healthcare. I suspect it's going to move higher in our database. Surgical errors are #3 in human healthcare, and then diagnostic errors are 4. Whereas what we actually see is when you think of especially during COVID, but think of all the interactions we have with our patients. We see a lot in this area that we've sort of labeled patient care and handling. So that's bringing the patient in from a car outside, handling the patient on, say, stretchers, even handling the patient as they come out of kennels or runs. And so all of the interactions that we have, even taking blood samples, that type of thing, it's a big category for us. #3 for us is anesthesia, and #4 is surgery and procedures. So you can see sort of a lot of similarities. One thing I wanted to share, I wanted to talk a little bit about a system. So this has been sort of my big project over the last 2 years, but I've been lucky to work with a global team. And so people from kind of around the world pulling together a patient safety event reporting system. And the name of this system is Halo. And that little guy there is sort of represents Halo. But essentially what we've done with this system is we just finished, we've had this system now functioning for about 1.5 years. We're still bringing new teams onto the system, but we've actually been able to also translate the system into 15 languages, including, so we have French Canadian, we have a number of different languages across Europe and Asia. And so what we're really trying to do is make sure that everybody can access this system and that it makes sense in different languages. So far right now, we have over 1,800 hospitals using the system, and you can see it spans a number of different kinds of hospitals. So primary care, urgent, emergency care, and specialty care, and we're across 8 countries right now, and so that is about to expand even further. The other thing I wanted to just mention is there's a number of different ways or decisions you have to make when you're making a system and how you're going to categorize things. And so you typically have sort of a minor level of category for when you're thinking of severity of a case. So minor is very normal classification, serious or severe is another classification, and then something that basically indicates, a patient that died related to that event. But one of the big categories that we're also focused on is a category we're calling high potential events. And these are essentially, if you think of events where, say you pulled up a medication, so say I pull up insulin for my patient and I'm walking towards the cage and I realize that, wow, that dose actually looks really large. And I'm going to go back and just rethink that. And I realized that actually I did pull up 10 times the amount of insulin that patient should have had. That would be what we would call a near miss, meaning that I caught it. For some reason, I was able to catch that event, but that there's something that led me to make that mistake. And so we're calling those kinds of cases high potential because they are great cases to learn from. If we could tackle all of the things we see in this high potential category, we could actually prevent the more serious kinds of events from happening. So I wanted to share actual data right now from our Halo system. And so right now we're close to about 20,000 events reported in the Halo system. And what you can, if you just focus on the left-hand side for now, you can see that 45% of those cases are in that near miss category. So it's one of those things where it's often when you're just starting reporting with a team, it's often the category that's easiest to report if you think about it, because it hasn't directly impacted a patient. Yet there are a lot of things you can learn from those near misses. If you look at the top in the middle, you can see that the top 3 patient safety event categories that we have right now are medication, patient care and handling, and anesthesia. And you can see the percentages of these. One thing we see, though, you can see anesthesia, sort of sedation, is at 12%, which is lower. But when we actually look at the more serious categories, so when we actually break it down into severity, anesthesia is number 1. So that's one of the things you have to consider when you're sort of trying to focus on how do we focus on the important things to prevent. You can see there are severity distributions. So you have more near misses typically in a system than you do a category like an unexpected death. And then I wanted to give you an example of a high potential event. So these are events that were caught but could have been really serious. And what we find right now in our database, which is really interesting, is that 30% of high potential events under the anesthetic category are related to setup of the anesthetic machine. And so if you were going to target, what's a really important thing for us to target to improve safety for patients in anesthesia, that would be a really good area to target on how can we, what kinds of things can we put in place to prevent those things from happening. The other thing, just to go through quickly on the right-hand side, you can see the distribution between dogs and cats. And what we actually see is that we do get more reports related to dogs, and we actually see dogs obviously more than cats. But what we see with cats is that cats tend to have more severe kinds of events. And so that is an important thing, and probably not that surprising for those of us that have worked with a lot of cats. The other thing I wanted to mention, though, is in this system, you have the ability to report confidentially. And when you start, depending on different cultures and countries, that may or may not be important to people. It typically is something that's interesting, is even though you see that option, you can see that only 8% or less of people actually use it. And I think that's encouraging, because I think these reports are entirely voluntary. And that's a really important aspect, because in a sense, I don't think we're at the point yet in every situation where we're openly talking about these. And this is a way for associates to tell their story. It's a way for you to say what happened so that we can proactively kind of look at it. And I do wonder if that's a piece of why confidentiality doesn't necessarily matter as much to people, especially once they realize that actually what we're really doing with these events is learning from them. The other thing in the lower right is that we actually so I'm going to talk about at the end the impact of these events. And in the Halo system, there is an option that asks if you have been impacted sort of emotionally by this event and would like support, please let us know. And that sort of is linked to a variety of different options and resources. So this is just the start, honestly, in veterinary medicine of kind of collecting this kind of data. But I think it's really important to realize that these events can definitely have an important impact. So I'm going to dive into now why errors happen. And one of the most important things that I'm going to say today is this, and it really does sort of focus on a systems-based approach. But what it is saying is that 95% of errors are made by well-trained, well-meaning, conscientious people who are caught in it, or trying to do their jobs really well, but are caught in faulty systems that set them up to make mistakes. And so what we're going to focus on is this concept of a systems-based approach. Essentially, when you see a patient safety event happen, one of the key things you should always ask yourself is, could that event happen to somebody else? And probably over 90% of the time, you're going to say yes. And if that's the case, then the solution is not to blame an individual. The solution is to fix the problem that led to that mistake. And so that is just such an important piece. It's basically a tenet of patient safety science. And I'll kind of give a little bit more background and a few examples of that. But when you look at this very simple display here, you can see the one on the left makes sense, right? It's making it easy to actually navigate that door. The one on the right makes no sense, and it makes it more complicated. And so I'm just going to show a couple of examples. But when you see, these are IV fluid bags, and especially for someone in emergency critical care, we will use hypertonic saline, which is on the left there, but very rarely in very, very careful ways in very small doses. The solution on the right is a normal crystalloid solution that we'll use in high volumes all the time with all sorts of cases. And you can see how visually it would be so easy to grab the wrong bag, particularly if they were placed right beside each other. There was no indication that, hey, that one on the left is a high-risk fluid. That's an important fluid. If we did something even as simple as separating these two fluids, and say we asked the company to put that writing, the writing of the name of the drug, in bright red, we probably would see less error. So if I'm the person that inadvertently grabs the wrong bag here, one of the first things you have to ask is, could somebody else do that? And the answer here is yes. And so the problem here isn't the individual. The problem is the way these are labeled, the way we place them in a hospital setting. And there are so many examples of this in a hospital. This is just one example. But this is the exact same concept with two different examples. If you look on the left, I think everyone's pretty familiar with the two drugs that are listed there. These two drugs come from the same company, and you can see that they look alike, they sort of sound alike. And if you think about it, think about where these are placed in a veterinary clinic. They're often actually, so they both have to be refrigerated, and they're often placed right beside each other in the fridge. And I'm not sure why we do that, but we do that. We tend to do that until you start thinking about it. And then you're like, well, obviously that would be better if we just, put them in completely separate areas, if we labeled them, different things. But even those vials on the right here, so you can see all of those brown bottles and how similarly they look, yet they are very different medication. You've got everything from vitamin B12, you've got you've got DexSP, you've got iron dextran. Those are all very, very different, but you could see how quickly you could grab the wrong bottle. So I think when you think about error and we talk about systems, and I'll dive into it a little bit more, you really have to step back and you have to not just think about that final step. It might be the nurse that gave the injection or the veterinarian that wrote the order, but what are those series of steps that may have factored in and led up to this actually happening? So I wanted to talk just a tiny bit about a system. So a system, essentially, if you think of a system as just a set of interconnected components that are there for a purpose. Now, this ranges hugely when you think of all the different examples, but a very simple thing could be just making a cup of coffee in the morning. So that, something like all the examples there, driving a car. We have a way that we might take a blood sample, and everything down to running an entire hospital ward or a whole veterinary practice. So a system is typically made up of a series of processes. And one of those things that when you are involved in a medication error is to kind of look at those processes and think, are there ways that we could strengthen that process? So just to go into the systems a little bit more, when you think of a really simple system, you think of something like baking a cake. Like we have probably something we're going to follow if we want it to turn out well. We're going to hope that we're going to do it in the right order. When we think of a more complicated system, think of an engine in a car, and then a very complex system. Think about veterinary care. If you think alone, just simply think of one thing, and it's the number of medications, products, fluids, inpatient, outpatient, and everything that we handle every single day. That alone is complex enough, let alone factor in, all the nuances of actually the surgical procedures that we do, the medical procedures we do, all the different decision-making processes that have to be part of it. So it is a very complex field. And so one of the things, when you think about a system, one of the key things you really want to realize is that all systems and processes can fail. So nothing is perfect. And what you really want to do when you see a medication error is to figure out, think about what are their weaknesses, like what led to that in the system, not the weaknesses with the individual. And then really trying to focus on finding, where are those unsafe conditions before that injury happens. And then I mentioned this sort of indirectly, but realizing that literally over 90% of errors are related to a complex series of events, not just a single event. So it is not just that person that made that decision to pull up that medication. Maybe that medication was pulled up maybe the wrong medication was pulled up because those vials tend to look alike and we've got them sitting right beside each other. There are so many things to consider with every single event. And what I'm sharing with you is are fairly basic examples, but this can become very complex. So this is a quote I really like from Don Norman, who is with the Institute of Healthcare Improvement. And he basically says, if the system lets you make the error, it's badly designed. And if the system induces you to make the error, then it's really badly designed. So I'm going to give you an example in veterinary medicine that is really badly designed that we need to tackle as a profession, and it is the anesthetic machine. So we have anesthetic machines right now. There are some newer ones coming out that are better, but we have anesthetic machines that allow us to completely close the system by screwing down the pop-off valve. And that is a weakness in that system. In human healthcare, they don't have that feature to their anesthetic machines. And yet, for some reason, we've accepted that in veterinary medicine. And what we do is now we're recommending to change the valve and put a safety relief pop-off valve on that it reaches a certain pressure, and all of a sudden it opens. But right now, that weakness in our system is leading to barotrauma cases for our patients when we forget inadvertently to open it. So if we just look at, say, the nurse that is doing anesthesia who is pulled in 16 directions trying to make sure this patient is safe and inadvertently forgets to release that pop-off valve, if we just blame that person, we're doing nothing to fix that machine. And so that machine, in my opinion, needs to be fixed on a much bigger scale by the people that make anesthetic machines. But the other thing that we can do as a profession right now is to retrofit these machines with a safety valve. And that will basically get rid of your barotrauma cases related to that problem. And so I just wanted to bring up it's a pretty key example, because I think we've all been we've all focused on that to make sure we don't make that mistake. So I wanted to, Kathy mentioned Swiss cheese, and this is a classic model in patient safety. So it's the Swiss cheese model of error. And essentially, if you think of each of the layers of Swiss cheese here, think of those as protective mechanisms, things that we try to put in place to prevent errors. And so we're looking at things like the people that work in a hospital, the way a team works together, but also things like equipment. Like we just talked about the anesthetic machine, different aspects of culture of a team, or leadership, or, procedures and things that you have in place. But like I said, none of these are perfect. And so each of them have little tiny holes in them. And when those holes actually become bigger and they align, so there really is a weakness, then you can see that can lead to medical error. And so this is just it's a key visual to think about. The way you think about these events is oftentimes we'll use this model when we're looking at breaking down a case and really trying to figure out what could have led to that case. And we will actually use it to talk through kind of each of these different areas. I'll just show a second one, which is a fishbone diagram, which essentially what you do here is you put the error in the head of the fish. So say for banks, I would put medication error. And then as you're thinking about medication error, you kind of go back spine by spine and you're asking yourself all the different categories. Did any of these factor in? And in most cases, you're going to have a couple of them, at least a couple of factors that do contribute to that error. And those help you decide, well, what are things that we could actually take action on and tackle to make things safer? So I'm going to just tackle this sort of quickly so that we can wrap up with impact. But this is a pretty fascinating field. So it's called human factors engineering, or human factors ergonomics. And it's essentially about how we as individuals interact within our work environment, within our home environment too. And it really looks at things like sort of the layout of the workplace, mental processes that kind of go into decision-making, and the way we communicate as teams, within a team. And it's interesting, but if you think about sort of normal safety features in your car, like think about getting in your car in the morning, you're a little bit late for work, you're carrying your coffee, you put your coffee in your car, you start your car, and you're trying to reverse your car, but then you realize you forgot to put your foot on the brake. Basically the other thing that you notice is as your car gets turned on, your headlights come on, and you figure out, you put your foot on the brake, and then you back out, you start to want to go forward, but you start hearing this very annoying chime because you forgot to put your seatbelt on. So think about all those safety features, the fact that without you doing anything, your lights came on, all you had to do was turn the car on. There's a reason why we have to put our foot on the brake before we get to put a car in reverse. And there's also a reason why that chime is there, to be so annoying that you're going to make sure you put your seatbelt on. And there are so many features now in safety, in this area of safety in cars, but essentially those are there because even if we tell people you have to wear your seatbelt, it's really important to keep you safe. We're human. Like, we're going to forget. We're not going to remember every single time. And that's exactly the way, when you look at a system and how to keep people safe, that's exactly one of the ways to think about it is with that kind of approach. So human factors it's essentially the study of all factors that really make it easier to do the work the right way. Think about it. If we had anesthetic machines without a pop-off valve and never had to worry about that again, that would be huge. And that is possible. So those are the kinds of things to really think about. And when you're actually looking at human factors, the two major areas are improved systems performance and then optimize human well-being. And you can probably see how those two things are actually pretty linked. So just as far as when we think about understanding patient safety events and culture, and essentially culture as well, we really want to think about, before jumping to a conclusion on the way to handle an event, particularly if you're thinking of reprimanding people, think about putting yourself in their shoes. Like, there are so many things that could have been happening that may have led to that. So thinking about why did they actually do what they did? And then a key thing is figuring out what features of the task, the job, the equipment actually might have led to that event being more likely to happen. And so this is basically kind of the study, the patient safety science behind patient safety event reporting, and importantly, creating a culture of safety. So when we talk about culture of safety, when I talked about banks, I think I didn't know it at the time, but I was in a team that actually had a really strong culture of safety, meaning that I didn't hesitate to tell the leader of that hospital that event had happened. And when I did, he was very accepting. He supported me as well as the rest of the team supported me. So essentially, when I talk about culture of safety, there's a definition there which talks about shared values, beliefs, and norms. Really, when you break it all down, it's about people getting your back. It really is. It's about being able to be human in your job. It's about being genuine. It's just about being yourself. And it really is, even in those very stressful moments, whether that's related to a patient safety event or something else, it's still about people supporting each other. And one of the reasons this is so important is that if you have a strong culture of safety, you're more likely to speak up. You're more likely to share your voice. And that directly has an impact on our patients. So not only does it impact ourselves, but it absolutely directly impacts patients. And so just to mention psychological safety when you're thinking through a patient safety lens, it really is the individual confidence that speaking up will not result in embarrassment, rejection, criticism, or punishment from others. And that is a critical thing. I think I've been lucky to be part of teams where this is definitely, it's just been accepted. It's been the way we do things. But I've also been led team or been part of teams where this isn't the case, where there are struggles with this. And that is exactly what I think we really need to focus on. So a strong culture of safety very much supports psychological safety, as all team members, regardless of position or rank, have a voice. And when you think of sort of power dynamics, or you think of hierarchies, however you look at it, which is still unfortunately there in many aspects in healthcare, this is exactly what helps flatten it. So when we look at why this matters, it really is related to key outcomes. And this is information from human healthcare, and they focused on patient outcomes and clinician outcomes. But you can see it directly impacts people's ability to speak up on behalf of patients. And that actually directly under patients leads to things like infection rates, sepsis in patients, post-op hemorrhage, the things that say somebody might be tracking or monitoring a patient, but they are not necessarily feeling like they have the ability to have a voice or to overrule somebody if we're going down a different path. Clinician wise, and this is just, this would be the entire medical team in my opinion, but the impact on honestly engagement, burnout, and turnover is such an important thing that I think all of us, if you think about teams that you've been part of, whether it's a medical team or a sports team, it makes such a difference to feel like you're truly a team member that's supported and accepted in that team. And that's exactly what this is looking at. So we've kind of gone through these, but just really what this is about is people feeling comfortable speaking up, asking for help. It's also very much a learning environment. So it's that environment where, say somebody that maybe hasn't done a procedure frequently a number of times can say to somebody else, hey, can you look over my shoulder? It is, and this is why we talk about this so much in errors, but errors are often one of the most stressful things that happen. But it is definitely encompasses a culture where we discuss errors, where we dissect them, and where we're really focusing on learning from them. I think, I was worried I'm running out of time, but just really quickly. So I wanted to just talk about how patient safety events, so if you look at little halo and then the bigger yellow box, that is kind of all events that happen in a hospital setting. We don't, in human healthcare, what they see is probably honestly only those numbers I shared in human healthcare based on the fact that probably only 40% of all events are reported. So that's pretty remarkable, knowing that 60% of events probably aren't actually reported. So realistically, because this is voluntary reporting, particularly right now in veterinary medicine, we don't get everything that happens, but we do in the gray box get a number of reported events. And one of the key things to do, what is going to encourage people to continue to report events so we can continue to learn, is for them to see action from those events. And so you can see if you go to the right, if we tackle those events, we really look at them, we try to analyze them, and then we put them in a cycle where we're testing things that might improve part of the system. Then we make sure that we feed that information back to the people that actually submitted those cases. That's a really key part of developing what we call a culture of safety. And you could do this with a number of sort of stressful areas in a hospital, but patient safety event reporting, like I said, because it impacts patients, it's often one of the most stressful and sensitive things. And so if a team does this really well, I guarantee you it's going to filter into all other areas of the way we interact as teams. And then I just wanted to mention, we don't have to go into a lot of detail of this, but there is in human healthcare ways to measure culture of safety in a team. And it is typically via survey. You need a really good survey return greater than 60% for it to truly reflect culture. Ideally, you're up in the 70s. But if you read those questions, you can see how I think most of them would really resonate with our team. And one of the key things is, and this again is human healthcare, the way this is worded, but I would feel safe being treated here as a patient. Another way to ask that question would be, would you have your own pet treated in this hospital? Medication errors are handled appropriately in this work setting. I'm encouraged by others in this work setting to report any patient safety concerns I have. And the culture in this work setting makes it easy to learn from others. Those are such key things. There actually are 2 validated surveys right now in veterinary medicine. They're just not used kind of that frequently, but hoping that we gain more and more traction with that. So I'm just going to wrap up by talking about impact of patient safety events. And I'm just going to quickly go through a case. This is Bosley. So he's an older male Labrador, and he ended up presenting with a cervical disc. And Bosley actually went through sort of diagnostics. He had an MRI. He went through a surgery for this disc. Everything went really, really well. And within 24 hours, I think it was 48 hours, Bosley went home. Bosley represented about 3 days later in extreme pain. And it was a situation that didn't really make sense. But as they started to examine him, what they started to see were wounds all along his back. And essentially, this is a graphic photo, but essentially what had happened with Bosley was he had been burned by a warming device that he was lying on top of during surgery, and it didn't manifest for a period of time after surgery. But essentially what they found with this type of device was that the actual temperature gauge wasn't working. When you look at this kind of a case, anyone knows that like this is a very complex case. So Bosley was managed over multiple days in the hospital, had multiple procedures, wet to dry bandages, a lot of wound care to recover from this burn. And he did definitely recover. But think of the pressure, think of sort of all of the emotion involved in a case like this, not only related to sort of the time it takes, but the fact that, we thought we did everything perfectly right. Bosley did amazing initially, and then this happens. And so one of the key things when you think about patient safety events is kind of that ripple effect, is the fact that there are a lot of impacts in these events that go much beyond the patient themselves. And I think the two things I really wanted to focus on here are kind of that emotional impact and the increased stress that these events can create for our associates. We actually in veterinary medicine, we have one and almost two actual publications in this area. Dr. Lori Kogan from CSU is a psychologist who looked at the impact of patient safety events on veterinarians. So that was the survey population. And I think it was about 600 veterinarians. And basically they found that about 3/4 of veterinarians in this study had experienced one or more adverse events in the previous 12 months. And then they actually, of those people, 50% reported that these adverse events affected both professional and personal lives. And then a second study that I'm excited to be able to chat about. I did a study just recently with Lori Kogan out of CSU. And essentially what we were looking at is the impact of patient safety events on the entire veterinary hospital team. And we were looking specific. So our database were our 3 groups in North America, but also all members of AHA, as well as the ACVIM diplomats. So we wanted a mix of veterinary professionals. And what we actually found, if you look at the stats over to the right, you can see that these events have an impact. So we had probably, I think, 2,300 people as part of this study. 50% felt that they were embarrassed from these events. They worry about, future occurrence of these events. And I think we all know that anybody that's on this call that's been through one of these knows that you think about these events, that these are things that are not easy to stop thinking about, especially depending on, the outcome and all the different factors that go into that. But also thinking about the fact that these really they can really have an impact on confidence level. The fact that we start to question, should I do that procedure or thing, whatever that was, again, whether we're actually good healthcare providers. So you can see that these clearly have an impact. There's also some really positive things that we found here, and I'll just mention those in a second, but we wanted to find out, do these events have an impact? And then if they do, how can we provide support for these events? And that's the piece I'll mention in just a second. There's a really important concept called the second victim syndrome that's come out of human healthcare, and it's come out of Johns Hopkins at Human Healthcare, where what they've realized over the last decade or more is that healthcare providers are impacted as well. So that if you consider the patient and the family sort of the first victim, that there is this whole concept that actually the healthcare providers, it's so meaningful, emotional, impactful for them, that is also something we have to closely look at in the people that are involved. And these are the kinds of feelings, the fact that you might feel responsible for the outcome, you feel like you failed your patient, and then you start to question, your own abilities. When we break down this kind of a syndrome, these are different kinds of feelings that people might feel individually. And I also think importantly, one of the key things that I really, really worry about is how does the team around an individual react? And you know that feeling when you're accepted by a team and where, you know, people do get your back. I hope not too many people know that feeling where that's the opposite, where you might get ostracized, or, you know, people won't ask you to help them anymore because of something like this, because it's such an important aspect of being an effective team, is actually being able to support each other. You can see just some statistics, but that this is it. It has a big impact. And again, this is on human healthcare. We don't have a lot of statistics yet. We've got, like I said, those 2 publications that you know, represent veterinary medicine, but I think you will see more and more, because I think more and more we really need to just dive into this area and figure out how it truly has an impact. One of the things that I wanted to point out is, so one of the big, I was excited to hear Kathy talk about the CVMA Pure platform, because what Johns Hopkins, who's a leader in this area, has found is it's probably now 9 years ago, they started a network called RISE, and it stands for Resilience in Stressful Events. And essentially, this is an entirely voluntary network. It started within the Hopkins system, which is a series of 7 hospitals. And basically what it is it's a network of peers that are available 24/7, basically as peers for anybody that wants to talk or have someone listen that's been through a patient safety event. That's how it started. Now it has really, really grown. It particularly grew during COVID, where Hopkins has become a teacher in this area for other institutions. And the RISE network now has over 150 human healthcare organizations. It's also had a couple of our teams go through training with them to learn how to develop a peer support network for their own, you know, healthcare members within hospitals. And so during COVID, what they really found is that it wasn't only patient safety events, it was lots of different stressful things that were happening to the healthcare teams. And this network of peers became a key supporter for people that were struggling, you know, to deal with these kinds of stressful events. So it's such an extremely important aspect. And when we actually, in that study I just shared, when we asked the members that took that survey how we could support you, 2 things really stood out to me. And one is that peer support was chosen by over 75% of people, that they thought, and you know, it's interesting. When I think of the patient safety events I've been through, naturally you might think you would automatically go to leaders and things, but I think the most comfortable is going to people that truly understand that feeling themselves. And so that is exactly, I think, where this peer support concept comes in. The second thing that I think is really positive that I don't know is really replicated in human healthcare is they felt that a strong aspect of support in veterinary medicine is the hospital administrator. So whether you call that a manager, you know, it doesn't. So I don't think in every case it looks like in veterinary medicine it needs to be a medical person, because the hospital administrator also had a very high percentage as a very good support role. And I think, again, this publication will come out and we'll learn more as we do more. But I think when we think about how do we actually support someone that's gone through something like this, honestly, you're not necessarily, like, sometimes when I think about people that have told me about events, sometimes it's just somebody to listen. It's not necessarily, you're not trying to necessarily fix the situation. You're trying to be an ear to listen. And, you know, one thing Kathy and I were chatting about is the impact of social workers on this kind of a situation. And I've definitely been we're lucky enough to have some social workers within our teams. And I've definitely been part of situations where, you know, a tough patient safety event has happened and an entire team or unit is affected, and where a social worker has come in and facilitated discussion and literally just been sort of that person that unites the team, that listens, that pulls people together and allows people to talk about what they're thinking about, which is such a key thing, because it's one of those things that if we just bury it and we don't kind of talk about it, then it doesn't become easier to talk about the next time. So I just wanted to point out that these events can have a big impact. We know that. We've got some data, not enough, but we've got some that suggest that. And there are some really good ways that have been successful in human healthcare to support people. And that is kind of exactly the path I think that we need to consider. So Just again, this is just literature showing, peer support programs, the importance of the second victim, the concept of, how do we actually support people? And then lastly, I just wanted to end by really focusing on, the fact that we know that this is a top leading cause of injury, of death in human healthcare. We also know that the same errors that impact our patients can also traumatize our healthcare workers. And so I think if we reflect that veterinary medicine follows human healthcare in so many different ways, and I think even in a sense, potentially or even more empathetic in many ways, and have even, just different types of pressure, that I think more and more we're going to collect more data that shows that there is a significant similar things happen in veterinary healthcare. And so happy to take any questions. I know we're kind of at time, and I apologize for that. I just wanted to kind of hit some key points, but.
Oh, thank you so much, Rochelle. And there is a question that has come in, which is, what's the general impression of the reporting clinicians of their ability to implement changes as a result of the incident? And further to that, what was the reporting clinician's ability to implement changes within their hospital?
I think each situation is going to vary a little bit. What I'm really hoping, typically most situations have, that there might be a medical leader in that hospital. And maybe that medical leader is a veterinarian, maybe it's a technician, but somebody that is driving some of the different, processes and things that you put in place from a medical perspective. It may be an owner of a hospital, which may or may not have a different dynamic. But I think the key, I mean, I think the key is starting the process. Like I remember the first hospital that I became part of, I just started to see things that I thought we could do differently. And it wasn't necessarily fueled at the time by errors that I saw, but it was sort of, I wonder if people are going to be okay if I suggest that we do something this way. And I ended up connecting with people that were able to make those things happen. And then over time, they sort of it sort of created a bit of a culture where everybody started kind of coming up with suggestions and solutions. And now it became very much a part of our culture that we would make sure that the top medical leader or the veterinary nurse would be aligned with whatever ideas that were happening. So they were very aware of them, but they weren't necessarily the only ones driving it. And that is when you get to that point, particularly even just with good ideas, let alone related to a medical error. But that is exactly how I think you just start that conversation. So you may feel a little powerless at this point, but I feel like I just encourage people to take that risk, just ask the question. And what I would really hope is that we can get this message to those people that are in medical leadership type roles, or they are leading a clinic. Because this, in the end, if you think about, we're preventing problems that will impact our patients, problems that might upset our clients, problems that could lead to financial payout, like so many things that are beneficial for the owner of a hospital or the leader of a practice. And so there are so many reasons why that makes sense to really empower. Like the best kinds of medical changes are made at the hospital level. They truly are. And so that's what I've seen as I've been in this field. So that's the kind of approach I would take. Not easy though. I mean, you may get turned down, and I got turned down several times too. But I would just encourage you not to give up and just take a different tact or go to a different person. Like there's a lot of different ways you can do it, but I think it's the right thing to fight for.
You're right. Tenacity, courage, and vulnerability.
Right. Right. Exactly.
Wonderful. Thank you. And there are amazing, like comments, great insight, wonderful webinar, a lot of great accolades coming in the chat. Someone has said mistakes are better termed inadvertent learning opportunities. So that shift in perspective, incredible. I realize I lost my clock somewhere on my screen. Oh, we're a little bit after the top of the hour. However, if you need to jump off, please do so. Remember that this webinar is recorded. We'll stay on if there's any further questions, and I'll keep the recording going so that you can come back and listen even to the tail end of the recording if you need to leave and want to hear some answers to the questions. One person asks, is there a contact for you, Rochelle? Love to speak at their hospital. Love to have you as a speaker at their hospital. So that's wonderful.
Oh, amazing. Yes, so absolutely. I didn't write it on this, which I should have. Let me make sure you get that, Kathy. My
Why
email,
don't we we'll put it in the chat right now.
Okay.
So
Yeah.
it's
And
Rochelle.low.
Rochelle.low, yep, at
Okay.
EFFEM.com.
EFFEM.com. Okay.
EFF,
Hopefully
yep.
I think I just sent it to one person. I have to send it to everyone. One moment here. I'll just make sure I can send to everyone in the meeting. And love too that uplifting and the value of social workers in the veterinary team, and particularly when it comes to maybe debriefing and doing a post-mortem, so to speak, on some of these medical errors. And a reminder that Dr. Corinne Mayette is on the call today. She is our safety supporter. She's also on our wellness committee for the CVMA and is a veterinarian and social worker. So Corinne, if you want to put your email into the chat too, so that folks can reach out, because this is the value, I think, too, of peer support. You know, the more we can engage each other to support, to help, to identify ways of doing things differently. We can't do this alone. And I think the quote at the very beginning was beautiful, Rochelle, that medical errors are a part of who we are as people. We're vulnerable as people. And then the more people we have around us who can support us and help us, the better.
Right, right.
Yeah. So some folks are still on the line. One thing that was really meaningful to me and better understanding my neurodiverse or neurodivine characteristics is that cognitive and sensory element, that when we're really busy and our brains are cognitively in overload and we're opening up the fridge, and this has happened to me, to reach for a vaccine vial, visually they may all look, well, I shouldn't say they all look the same, but they can look very similar. And so then we may start looking for either the feeling of a touch or even pattern recognition to make that decision. And I was in a situation where I did give the wrong vaccine to a patient. And afterwards, we looked at the fridges and we made sure that all the fridges had the same pattern. So where the lepto vaccine was in one fridge was the same as in another fridge. So that in those really busy moments, it helps to reduce the risk of errors from those sensory and affective ways of making meaning of what we see or what we touch, you know, the feeling, the pattern part of it.
Right, right. You know, it's interesting. We've all probably seen this. I mean, even thinking of in the grocery store, but the concept that they use, actually, it originated in marketing, and if they use a concept called a planogram, which essentially what they're doing, if you go into any grocery store and you look at popular aisles and you look at where things are placed, the things that they're not marketing as heavily are right at the bottom or right at the top. And that's because we have a certain visual space that we tend to focus on. And then they will do other techniques within that planogram that actually make things pop out or not pop out. So that whole concept has been adopted by pharmacies in human healthcare. And so right now, actually, one of our big focuses for the teams that I'm working with is actually a whole focus on pharmacy organization and medication safety. And so it's that concept of, if we have certain high-risk drugs, particularly that we know we mix up, let's make sure that they are placed very strategically so they aren't right beside each other. Or like you mentioned, like there's a color indicator, or even a concept of putting a shelf divider in between makes us think differently. It's the same. I mentioned human factors because that's exactly the science that drives this. It's the reason that we stop at a red light. We don't, if that red light was, say, baby blue, we would not have the same reaction to it, because red to us is important, orange is important, right? So that is all sort of this whole area of cognitive behavior that I'm learning a lot about and finding pretty fascinating. But when you see the simple examples, you're like, oh yeah, I do that all the time. Like, you know, and so it's these kinds of things to try to understand and then honestly test in small ways. Like you can't, if you think of your pharmacy shelves, if you changed everything right away, people would be confused, it would be chaotic. But if you just change one or two simple things, like, you know, one of the things we know in our data as we break down that whole area of medication safety, we mix up cat and dog vaccines all the time, and we mix up cat and dog products all the time. Now, maybe those don't lead to egregious error, but they certainly lead to frustration and things on behalf of a client if we detect them, and they also don't protect the pet effectively. So essentially, if you in a fridge make a shelf for cats and a shelf for dogs, right there, you've made a difference, and you put a little cat on the shelf and you put, even the idea of labeling certain drugs with red high risk drug stickers, if you've got insulin on your shelf. Like, there are some really important, really simple things that are cost effective that could help us just, organize the system better. So that's exactly the kind of focus that I think if people see that, they're like, oh, that's encouraging. I'm going to, keep reporting events.
Absolutely, when they see the changes, and the changes can be made at that environmental level. I love what you shared about the work that you're doing with pharmacies. And it makes me think that our next webinar in this series of Merck Animal Health, CVMA, Time to Talk About Mental Health and Vet Med, is on sensory, cognitive, and physical aspects of our clinic environments and how to modify the environment for a better experience for both like clients and teams.
Right.
So I put that in the chat. That will be in December. We're just nailing down the date now. And if folks are interested in, we need to hear from veterinary clinics on what's happening and then how we can make those improvements. So if anyone wants to be a subject matter expert to help us shape the webinar content, my email address is in the chat. So please do reach out. And I just want to thank you so much, Dr. Lowe, for sharing your insights, the evidence-based approach, the true sense of being a caring person in the profession. You bring this information both from an evidence perspective, your own lived experience. So thank you for that vulnerability and that courage at the beginning. And then it really helps, I think really helps all of us to level set that we're all in this together. We are humans. We're in a way working in a faulty system. We're working with biological entities like animals as well as people, and they are very prone to unpredictable events. And I would like to leave with another quote, which is, we are all allowed to be a masterpiece and a work in progress at the same time. And that came from an actress named Sophia Bush. And to me, this quote really encourages self-acceptance and self-compassion and serves as a reminder that as folks, we're doing the best we can in the moment with what we have. So please be kind to yourself, be kind to each other, foster that culture of support and psychological safety in your teams, in your clinics, and in your lives.